Okay, let's get started. Camille will be going to each person, as will Nadia. So do we have some questions to start off?
Yep, we've got Holly right here.
Hi, I'm Holly. I'm from Massachusetts. I just had a quick question. I have multiple sclerosis as well as sarcoidosis. And with the sarcoid, I originally found out all the lymph nodes in my chest came back enlarged on a routine MRI for the MS. And I take 20 milligrams of prednisone a day. And my doctor really keeps encouraging me to come off it. But as soon as I go down to even 18 milligrams, I get this vicious cough and I can't stop coughing. And so if you had a patient that, I mean, is it that important to come off of the prednisone, or, is there something else that you would recommend?
Yeah. Well, we try and get everyone to at least 10 milligrams a day of prednisone or lower because of the side effects. I mean, it's certainly bone demineralization, weight gain, hypertension, diabetes are all side effects of steroids. So that's the main reason for trying to lower the dose of prednisone. But obviously, if somebody has significant symptoms that they can't do it, it's a problem. And then they have to suffer the side effects of the prednisone. Another thing I would just like to mention, there's a lot of times it's difficult differentiating multiple sclerosis from CNS sarcoid. And we've seen a number of patients who sometimes have been called MS who've been later diagnosed with sarcoid. And it can sometimes be a very difficult differential to be sure which is the cause. But again, both CNS sarcoid and multiple sclerosis are very difficult diseases, and certainly CNS sarcoid tends to be a disease that's really chronic and really is probably one of the forms of sarcoid that probably requires lifelong therapy.
And I'd like to add something, sorry, real quick, is again, and I know we had referred to it before, was they are looking at that drug Acthar around, does it have the same toxicity as steroids exactly, or could it be better tolerated for people who can't tolerate steroids? It's still, in trials, and as Dr. Rossman indicated, there will be a publication soon around some of that.
Yeah. The other thing just to mention is if cough and other problems are symptoms that you get with tapering steroids, sometimes inhaled agents sometimes are helpful for treating those symptoms. And certainly, we try and use the simplest and least toxic treatment available always.
Okay, next question back here.
Yes. What is the normal time for if you take methotrexate to stay on? It's over 2 years. Too much? Too long of a time?
Do you want to do it?
Sure. So, is it methotrexate you were referring to? Sorry,
Yes.
let's see where the,
And it's going on 2 years. Can you
Right.
stay on a drug that long of that high, of that type?
Sure. So I'll start with an answer, and perhaps Dr. Rossman can fill in, maybe give a little bit more of a historical perspective. In general, at least for the way we typically use methotrexate and some of these other medications, methotrexate, I think if you look in the older literature, there certainly were a lot of concerns about liver toxicity. It's not exactly clear whether or not it's in part because higher doses were used, or whether or not it's because they were looking at methotrexate use in other types of diseases. I would say, at least in general, our experience in our clinic is that we certainly have had many patients remain on methotrexate for many years, and that the old concerns about getting liver biopsy after X number of years or X number of grams that a patient may have taken methotrexate really aren't recommended anymore. And again, it may be because, particularly for sarcoidosis, we're not using particularly high doses of methotrexate compared to how methotrexate may have been handled many years ago. It's still very important, as Dr. Rossman mentioned before, to monitor blood work regularly. I would say in most situations, if a person's going to have problems with methotrexate, we tend to see it up front, perhaps within the first several months. But it still remains important, either after a year or 2 years, to have blood work drawn essentially every 3 to 4 months, just to make sure the liver enzymes don't change. So, Dr. Rossman, I don't know if you have any other thoughts about how we might think about methotrexate now versus, like, say, 20, 30 years ago. When it was.
Yeah, I think the doses that we use generally in sarcoid are usually don't cause significant problems with the liver, and so it can be used long term. And I think the only reason for stopping it would be toxicity, though. Again, with any drug used for sarcoid, hopefully the drug puts the sarcoid in remission, and then the only way to know whether the sarcoid is still active is to slowly cut back on the drug and see whether the sarcoid
Cut back
manifests.
on the methyl.
The only way to know whether the sarcoid is still active is to cut back on the drug to see whether the sarcoid comes back again. But again, we always encourage that people should use the lowest drug possible that controls their sarcoid. And that's sort of the ultimate of personalized medicine, because everybody is different. And so it's always a trial where you sort of decide what you're treating and how you're following it. And then you hopefully get it in remission and control. And then once it's in control for several months or a year, then you slowly try and cut back to see whether it's still needed. And the only way to know is trial and error, unfortunately.
Okay.
Okay, thank you. Next question.
Acknowledging that the causes of sarcoidosis are unknown at this point, is there any indication that any other non-traditional, besides the Tai Chi, any other non-traditional treatments are beneficial or showing any kind of promise? In particular, diet, and in particular within the diets, the ketogenic diet.
You guys have any thoughts about that?
That doesn't sound like anybody has any experience with it.
Yeah, I can't say. The Tai Chi certainly holds for fibromyalgia. I think some of the non-sarcoid related things. The ketogenic diet, has some, maybe biochemical appeal when you look at diagrams of the immune system, and thinking back even to things that we're taught in undergraduate classes, but I don't know of any evidence that's borne that out in a clinical setting.
Maybe I could just add a comment. I think there's certainly a lot of interest in whether or not, eating a certain diet or certain foods might affect the immune system in some way. What we are not trying to talk about would be people who clearly have, say, allergic reactions to certain foods, which has garnered a lot of attention in the press. Celiac disease, issues with gluten. I mean, real, true issues with gluten, for example, where that's a known issue that can stimulate the immune system. Other than that, there really hasn't been any great body of evidence to support that diet is going to have a big impact or replace medications in many of these cases. I think, there's certainly some, if we were to just speak openly, there's certainly some theoretical concerns that certain things in over-processed foods might stimulate the immune system, but there's really not enough information for us to say specifically you should avoid X, Y, and Z, other than, if you have one of these true, allergy issues with certain foods.
Okay, thank you. Next question.
Yes. I'm from Philadelphia. I came down and I saw you, Dr. Chen, and I saw Dr. Newman, and I saw Dr. Pardo. And this is my second time coming to a sarcoid conference, I guess. Okay. And my question is, I hear you guys say the central nervous system. Most people don't discuss neurosarcoidosis, and that's where my trouble is. I just had a wonderful neurologist at Jefferson work with me for the last 2 years, and he passed a couple of early this month. So I'm without a neurologist. Also, I'm on Imuron, where I'm having the blood work done every week, and so I'm just curious. I'm struggling with walking. And could there be a combination of medicines you can use, since now I had a wonderful neurologist that I was working with at Jefferson. Can there be a combination, because I'm struggling harder now with walking? I done had 2 surgeries on my spine. They put me on prednisone. The prednisone caused me to have hip replacement, AVN. So I have tingling in my hands and numbness, and you know, the tingling and the numbness, and walking is harder now. So is there a combination of medicines that I can look for? And I'm a research guru. I'm on top of this thing. Believe me, I'm on top of it. So
I think as
any suggestions?
I think as I mentioned, CNS sarcoid is a particularly difficult form of sarcoid to treat, and certainly one of the things is there are very few neurologists who really specialize in sarcoidosis.
Right.
And part of the manifestations is that CNS sarcoid can really manifest itself as a variety of ways. People can have strokes or epilepsy or other things, and so you need to find a neurologist that actually deals with the form of CNS disease that you're dealing with. And then usually it's in combination with somebody who's familiar with sarcoid, who's working closely with the neurologist and using the various drugs that we have available to treat sarcoidosis. So it's really, you know, getting a combination of physicians who are both interested in sarcoid and also who know the CNS disease to work together. And it can be difficult sometimes finding the right combination of physicians for this. I mean, certainly one of the examples for this is the founder of FSR, who I mentioned had CNS sarcoid and had a difficult time finding physicians to sort of treat her disease. So I think you need to work both with neurologists and with physicians who know sarcoid to find the combination of drugs that will work for you.
Okay. Are you from Philadelphia? Because I heard you.
Yes, I'm at the University of Pennsylvania.
Okay, I was just curious. Okay. All right, thank you.
Okay, thank you. Moving on.
Oh, hold on, we're gonna.
Actually, I just, one comment. I think in terms of, one issue you bring up would be an important one for probably many patients in the United States who have long-term active disease, right? And so one important question is to make sure the disease remains under control. Setting that issue aside, I mean, particularly as the years pass, we also have to make sure that there are other issues that might need to be treated with approaches other than simply medications. And one big category would be physical therapy, rehabilitation, Tai Chi, and meaning that, for example, what sounds like in your case, which is not uncommon, person gets sick, they don't feel well, they become less active. They may incur other problems like what you mentioned, for example, the hip replacements, where we know that you were probably also less active trying to recover from that. People get deconditioned just on a very simple, thought process. And then, it's hard for them to kind of dig themselves out of that. They were sick to begin with, now they're also deconditioned. And so I think that, and even on top of that, if you mention neurosarcoidosis, where a person's probably not able to be active also, physical therapy is very important. And so even if you may have had a course of physical therapy years ago, maybe just a couple of years ago, maybe with your last hip replacement, if you're having difficulties now, it's something to really reconsider. I would say that it's also, in particular, important for patients with neurosarcoidosis. Physical therapy is important. It doesn't replace the medications, but it's really important to kind of get people back on their feet and active again.
Okay, thank you. Moving on.
Good afternoon, everyone. My name is Rhonda Underhill, and I just wanted to encourage you and let you know that there may be something that someone at Johns Hopkins can do for you, and that you can speak to Dr. Eric Newsom, and I'll give you his number.
Thank you. Sorry about that. We just want to make sure we get everyone's questions going forward. And maybe you had a question.
How do I get in touch with other people in my area that have sarcoid?
That's for Ginger.
Yeah, yeah, I can answer that one. I have a number of good answers, but one of the things is, the Foundation for Sarcoidosis Research, one of our very critical mission points beyond advancing research is connecting patients, because that's a big part of it too. We have, if you go to our website, you can certainly see, some of the resources we have, but quickly, we have an online community of 22,000 patients. It's an easy way to connect with other patients, right down to being able to tell your stories, which is highly important. By no means is that not important, but sometimes there's not a forum for it, right? So that, getting advice, getting referrals for or recommendations for doctors, those types of things. It's called, our group is called Stop Sarcoidosis, and it's on a platform called Inspire. But if you simply go to our website, it will lead you right to it. And you just do a little profile, and you don't have to identify yourself. You make up a nice name and all that, and you can get all your information. In addition, at conferences like this, and you'll see later after or at lunch, we will be connecting, hopefully connecting you to each other. Sometimes you just need a phone call. And then finally, another thing that we're working on, and we don't have yet, but soon we'll have, is we're looking for patients who might want to serve as ambassadors of sorts, who would be willing to take, kind of be that front line for a call for a newly diagnosed patient. Somebody who would say, I'd be happy to go ahead and schedule, 3 hours on a Saturday, and people can sign up with me, and we can talk, or however we arrange it. But I think that that's highly important, and we want to make sure that everyone understands by no means that is part of your recovery as it is, or your healing and all that is having connections. So do go to our website.
I just like to make one comment about what the patient said before. It's not uncommon for there to be a long delay in the diagnosis of sarcoidosis. Certainly, if people have skin sarcoidosis, a dermatologist can do a biopsy and make the diagnosis fairly easily. But certainly, it's known that for certainly people who present with lung sarcoidosis, there's usually several month delay. And I think for CNS sarcoid, it's probably even longer. Sarcoidosis is a diagnosis of exclusion, so there is no specific test that makes the diagnosis of sarcoid. Even the biopsy, we have to rule out by culture and other techniques. So there's, unfortunately, for many patients, a very long delay till they make the diagnosis. And I think for CNS sarcoid, it may be the longest.
Okay, thanks. Moving on. We've
Next
got questions in the back. Yeah.
Talking with our network of doctors, I'm finding difficulties finding them down in the Northern Virginia area, and I wanted to know if I could reach out to the doctors at Johns Hopkins if they could get me a starting point in the Washington, D.C. area, the Northern Virginia, Fairfax, Loudoun area, was one of my questions. I was a very fortunate patient, diagnosed at 28 within the lungs. We caught it early enough. We did a round of steroids. We were able to reverse it. Had flare-ups over the last 20 years. So I've been living with it that long. But my question for you is, have you all entertained, engaged, looked into, thought about the guaifenesin protocol? I discovered it only because of the fibro and found that it was flushing my lymph system to keep the lymph nodes from becoming blocked, and did not know if any of you all have looked at this or talked about it or would like more information about it. So.
I guess
I'm not familiar with
yeah, I'm not familiar with the guaifenesin protocol, but I'm certainly welcome to learn a little more about it. We could catch you later after the general session. I guess in the Northern Virginia area. So there are a couple ways of approaching that. I'm not here to tout our own horn, but certainly we do have some patients who drive up here from Northern Virginia. There certainly have been other, experts or physicians who have had a significant amount of experience with sarcoidosis. They tend to be found at university centers. For example, at Georgetown, I believe there used to be somebody there. And perhaps GW, yes. So I would start in local university centers. I believe that VCU and Medical College of Virginia. I've run to people at some meetings, and at least one of the two places there's actually an effort to start a sarcoidosis clinic. And so, again, I would look at local academic centers to start.
And FSR has a list.
Yeah, thank you, Dr. Milton. The other thing is, not to toot our own horn, but I will. We do have resources, again, on our website. We have a searchable directory, so you put in the area that you want, and it will give you a list of physicians that have some experience in sarcoidosis in that area.
Okay, next question.
This kind of piggybacks on some of the questions that have been asked. If you're a patient who has been diagnosed with pulmonary sarcoidosis, but you're having a lot of other symptoms which doctors who are not familiar with sarcoidosis would diagnose separately. Is there a benefit or a negative in terms of pursuing treatment for the conditions individually as opposed to having expert in sarcoidosis or a network of doctors who can help? Do you start out with a comprehensive assessment? I'm just trying to get a sense of the best approach.
Well, sarcoid is a systemic disease, so whenever somebody's been diagnosed with sarcoid, you need to look at all the organs to make sure there are other organs involved. And then depending on what somebody's particular involvement is, you need to get the right physicians who are familiar with that organ and what the damage is and what it can do. So a lot of times it involves a combination of physicians treating a patient, and you need to make sure that all the physicians are talking to each other.
Next
How do you make
question.
it easy?
How do you make it easier to have
Oh.
physicians talk?
I'm not sure it's always easy. It's because you got to get physicians to talk to each other. It's sometimes very difficult. Certainly with the advent of the electronic medical record, I know at our institution it's easier for us to talk within an institution to each other. I'm sure that's true at Hopkins also. If you're seeing physicians who are not on the same electronic medical record, then it becomes a bigger problem. And I think it's partly the patient's then responsibility to make sure that these physicians are talking to each other. If not, you probably need to find new physicians.
Okay, thank you. I just want to make one note. We're trying to move across the room, so I know everyone's raising their hands. We will get to you. We're just doing our best to get across the room. We got a question in the front here.
Hi, I'm Tricia Beisler. I'm also from Northern Virginia and originally kind of struggled to find the right place. I was originally diagnosed by Dr. Feller-Kopman there at Johns Hopkins. He helped me to really manage my lung symptoms, and I subsequently developed inflammatory arthritis, which I didn't really attribute to sarcoidosis. So I have a rheumatologist in Northern Virginia. Dr. Legan, I'd love to see you. Is it something you can just call your office, or do you need a referral from a specialist, or how does that work?
Yeah, you would probably need a referral from your primary care doctor,
Okay.
and they send it on to our office. They usually screen it just to make sure someone's tried to think about these things.
Okay.
Unfortunately, there's a little bit of a wait, but if there's any urgency to it, sometimes we can push things along as well.
Okay. And then my actual question is, I went through the protocol with my rheumatologist, was not able to tolerate the methotrexate because of the liver enzyme problems and really severe nausea, maybe some projectile vomiting. And then, so I've been doing the Enbrel, which I'm having better success with. She feels like it's important to still do the methotrexate in tandem with that because she feels like maybe that it helps to boost the effects of the Enbrel. Do you share that opinion? And also, do you feel like you see people who have granulomas in their liver have trouble with the liver enzymes that are from medicines? So I know that's two questions, but what do you think about the methotrexate and the Enbrel together? Is that important?
Yes, we often use them together in rheumatoid arthritis, and in part because, especially with prolonged use, the immune system will start to recognize the drug sometimes. The significance of that is a little bit up in the air. We know that treating with other DMARDs, those are things like methotrexate, sulfasalazine is another one, leflunomide or Arava is another one, does decrease the frequency that those antibodies are made. So usually, we'd recommend a low dose in addition to the TNF. The liver issue is a common one. We know that frequently patients with sarcoidosis have what's usually asymptomatic liver involvement. Sometimes it's just a matter of watching trajectory. If the liver enzymes have always been a little bit abnormal and they're still a little bit abnormal and you've done some imaging, oftentimes we can continue these medications at low dose and just make sure that we're getting blood work regularly so that there's no later increase. Unfortunately, all those medicines do have that kind of GI toxicity profile, so they can cause diarrhea, nausea. Those are common complaints. Once you've had a problem with methotrexate, usually leflunomide is kind of off the table as well. It has a very similar toxicity profile with it, but sometimes sulfasalazine works well for us in that situation. So there are other options of things that you can take in addition to it.
Okay, thank you.
Okay, thank you. We've got a question.
Cassandra McIntyre, Bowie, Maryland. Recently, I had a situation where I had an abnormal mammogram, and then a biopsy was done, and what was discovered was that it was a granuloma. So I would like to know from the panel, what is your experience with sarcoidosis of the breast?
I've had a couple patients who have sarcoidosis lesions in the breast, and yet generally it's because they have nodules that are biopsied and they have sarcoid and it's found. We had one patient a long time ago who had a typical syndrome of sarcoid, but there was a problem in the lab where there was actually a floater of a cancer that got into it. So they did multiple biopsies, including a breast biopsy, and they all came back as sarcoid. So sarcoid, as I mentioned, is a systemic disease. It can involve every organ, and it's always a diagnosis of exclusion. So just because you have sarcoid and nodule in your breast, you can't assume that it's sarcoid. You have to be sure that it's not cancer.
Okay, thanks. Next question.
I had a question for Dr. Cheng. First of all, thank you for your presentation on cardiac. My question simply is, how many patients do you follow and how do they usually present?
It's going to be hard for me to give you a number in terms of how many patients we follow, but what we have been trying to do more systematically is setting up a registry of cardiac patients. So we have about 80 individuals on that registry and follow them sort of throughout the time course. I sort of also want to point out, as Dr. Rossman mentioned, since sarcoid is a systemic or a total body sort of condition, it's uncommon to have just one cardiologist manage people with cardiac sarcoid. In fact, there are many different people. So, for instance, I'm a cardiac electrophysiologist, so I'm an electrician. And so, so I deal with the slow heart rate issues, the people who need pacemakers and defibrillators and stuff. And so I don't sort of focus too much on the immunosuppression agents, and I rely on these guys who are smarter than me to figure those things out and to sort of tackle the immune system. But I do get involved when people have arrhythmias and they have things of that sort, or their defibrillator fires, and figuring out sort of options to manage those things. And so I work as part of a team. And so collectively, at least at Hopkins, and I'm sure it's the same over at Penn, it's not just one individual. So very often when patients have cardiac sarcoid, I'm involved, as well as a heart failure specialist is involved, as well as a pulmonologist involved. And so there isn't sort of one individual that does it.
Okay, thank you.
All right, next question.
Hello, my name is Rodney Reese. I'm from Baton Rouge, Louisiana. Kind of piggybacking on the young lady with the breast granulomas found. That I also had granulomas found in my testicles, and first thing was cancer.
Right.
Well, they did biopsy of it, and the urologist called me and he informed me, well, good news, Mr. Rodney, you don't have cancer. Well, a few years later, I'm looking on the internet, I find an article of sarcoidosis in the testicles. And my pulmonary doctor in Baton Rouge had happened to write that article. So I printed it and I took it to him, and he looked at it, man, where did you get this from? So I said, off the internet. So he got the biopsy report from the urologist. And sure enough, on the biopsy report, it stated non-cancerous lesions, but non-caseating granulomas consistent with sarcoidosis. He said nothing to me about the sarcoidosis. Wow. That was 2 years later when I found that out. But my question is, it's not actually a question, I want to ask you all, what can we do? I'm presently on Remicade. Okay, I when I first got diagnosed with sarcoidosis, for 3.5 years, I averaged 80 milligrams of prednisone a day. That's a lot of prednisone. That's an average. I mean, I'd go down, you know, 10. Anytime I got below 20, my lung symptoms would flare back up. I'd been as high as 100. So we tried all the gambits of, I was on the methotrexate, the Remicade, I mean the Emuran, everything. I have a whole slide of medications I was on. So when I tried to get on the Remicade, my insurance company denied me. They said I needed to go through every sarcoidosis drug they had out there, which there are none, right? Okay, now I heard Ginger say they have one now that the FDA has approved for sarcoidosis. But my question is, how can we get these insurance companies to pay for these drugs that, now when I finally got, you know, they finally decided they would pay for the Remicade because my doctor, he appealed it, and they said their reason was, well, it's not a FDA approved sarcoidosis drug. So at that time, my doctor wrote him back and he told me, say, name me one FDA approved sarcoidosis drug and I will drop this. But they couldn't. So they gave, you know, they started paying for the Remicade. And it's the same thing with the PET scan. We talked about PET scans earlier. These insurance companies don't want to pay for these tests. What can we do? You know, I've been writing my congressman in D.C. and in Louisiana. You know, it's something we have to do. If there's stuff out there that can help us, and the insurance companies won't pay for it.
Yeah, I'd like to address that a little bit. First of all, thank you, Rodney, because we all know how much you do for this. You're a true advocate, and we appreciate it. A couple things. One of the central points of the mission of FSR is to inform everybody, all the stakeholders, right, about the burden of the disease and exactly. You know, very, very often you'll hear people who don't know, including in the insurance industry, who don't know about the disease saying, oh, that's that thing that goes away, right? And so what our role is, our job is to use our kind of neutral partner, our objective partner. You know, we're not a drug company, we're not doctors, we're not patients, you know, like to get that message across, because they will listen more. And in fact, the insurance companies as well as the pharmaceutical companies are reaching out more to patient advocacy groups like ourselves to get that information. And so to continue what you're doing, you know, the writing, and this is one of those cases where you can be very explicit about what the burden of this disease is on you. As also joining, you know, being a patient advocate, joining the patient advocacy, people are looking at that online community now, meaning people in the insurance companies are looking at that online Inspire community now to really get a sense of what's going on. So, you know, getting as involved as you can and asking pointed questions like that is really important. The other thing I did want to mention, I'm sorry, I do keep mentioning it, but I just want to make sure that it's clear that, so yeah, I did mention the FDA-approved drug. It's called Acthar, and it's ACTHAR, and it's, again, there will be a publication coming out soon around its use in trials right now. It has been FDA approved since, I believe, 1952. But it kind of went out of popularity of use, and now there are many trials where they're trying to gather more data about the use of this drug and where does it work, where doesn't it work, you know, it's probably not a frontline drug, but but it may have a place, and so definitely you know, that's something that you can look into as well.
Okay, thank you.
One other thing about the drug programs, the research programs. We have to get involved in these. I was flying up here to Bethesda, Maryland, to the NIH from Baton Rouge. They were doing a research on the drug pentoxifylline. You remember when they were doing that? Right. And I became a part of that because the prednisone was killing me. So we have to help these researchers find better drugs for us.
Wonderful. Thank you so
Thank you.
much. Moving on.
My wife was diagnosed with neurosarcoidosis 9 years ago, and they did brain biopsy, lung biopsy, the usual things. The unique thing is that they didn't find any granulomas, but by process of elimination said, well, she's got sarcoidosis. My question is, after 9 years, should tests be done again or something else be done to identify if she's really got sarcoidosis or if it's in combination with something else?
Well, again, it's difficult to respond individually, but the one of the problems with neurosarcoid is people can have a severe syndrome requiring immediate therapy. And one of the problems with therapy is it make the granulomas disappear. So it may be difficult to actually confirm the diagnosis. But you know, if somebody's life is at stake, you need to start therapy rather than trying to get tissue to confirm the diagnosis. And it's a real problem. And certainly for neurosarcoidosis, some of the highest dose of steroids and other medicines are used. And a lot of times because people are acutely ill, they'll be given IV pulse steroids and other things to treat them because it's a real medical emergency. And so it may be very difficult to ever confirm the diagnosis. And sometimes, you know, physicians have to do this. It's a question of, you know, it'd be nice to confirm the diagnosis, but the patient's health comes first.
Okay,
Okay,
thank
next
you.
question.
Good morning. First, I wanted to thank the foundation. What a great conference this is. And our panelists, each one, I probably have 2 or 3 pages written, so I'll be real direct. We had Dr. Yeager, who was at Georgetown, who was just passionate about sarcoidosis. He's no longer working, so I think I'm going to turn this to piggyback on with the other Northern Virginia ladies. Is there actually a sarcoidosis clinic at Johns Hopkins, and do I need, you know, almost to be invited in? Or, and when I say referral, I don't mean as in a insurance type of referral. So what is the process to start coming to Hopkins for someone who's just works on sarcoidosis only?
Right. So, as was mentioned, I mean, there are various sarcoidosis clinics around the United States. And at Hopkins, I think it just so happens that we've had, I think, one of the longer standing sarcoidosis, or like the longest continuously running sarcoidosis clinics in the United States. Anyway, so in terms of new patient referrals, you know, I can certainly give you a phone number it's generally to the pulmonary clinic. Like many sarcoidosis clinics, we originated within the pulmonary division. Because of the nature of our clinic, we not necessarily most of our patients have lung disease as their main problem. We field all sorts of cases, neurosarcoidosis, cardiac sarcoidosis, and such. I think just something that would be easy for me to pass on through a microphone, if you're in the habit of using email, you can just email sarcoidosis@jhmi.edu just to get the ball rolling. Usually, you know, we do require, like for many of the centers, at least either some clinic records, maybe a summary letter of some sort. And you don't necessarily have to be invited, but it does take some time to get in sometimes. What really would help us sort out how urgent the matter might be would be some kind of message, or again, maybe even just a letter from your doctor. Otherwise, we often get stacks of records. We'll look through them, even if we'll see that the patient does have either a reasonable confirmed diagnosis or reasonable to suspect sarcoidosis, but without that letter to say, like, to describe like how urgent it is or what the nature of the consultation is. Sometimes it's just a second opinion, but that would help in terms of, you know, for the sicker patients perhaps to be considered more sooner. Thanks.
Okay, thank you. Next question.
I have a question about sarcoidosis in the bones. If someone has it in the vertebrae, but they're asymptomatic, do they need treatment? Do they know if sarcoidosis affects the structure of the bones? Does it predispose to fractures? And is there a concern that it would go into the spinal cord, even though it doesn't show that it's in the spinal cord?
I think generally we don't treat sarcoid if it's the bone. If somebody's having bone pain, then that's something that would be treated, but just a radiologic lesion in the bone is usually not treated. And certainly sarcoid can involve the bone marrow. It's rare, but it does occur. But that's usually not based on X-ray studies. It's based on studies of the bone marrow or the CBC.
So just because it's in the vertebrae, it doesn't mean it's going to go into the spinal column. It doesn't mean it has to be treated to prevent that.
Yeah, they're probably two separate disease processes, you know, a little bit different types of people that get the bone involvement and get the neurologic involvement, particularly CNS involvement. And then also, I guess the one thing you do want to be careful of, again, you know, with sarcoidosis, it's a diagnosis of exclusion. So whenever we see a lesion on an X-ray or a CT scan, particularly of the low back, the spine, the first thing we really worry about is metastatic cancer, unfortunately. So that's something that needs to be thought about, and, you know, make sure that, you know, sometimes they need to take biopsies. I suppose maybe not all the time, but certainly doing screening, appropriate screening for those kinds of conditions is a concern.
Okay, thank you. We've got one more question in the back, and then we're going to move our way around.
Okay, next question.
My question is, do granulomas in the liver, when there are no symptoms and there are normal liver function tests, typically progress to scarring if not treated?
So that's a very interesting question. Obviously, if you're describing a situation that you're experiencing, there must have been some other reason for the biopsy to begin with. But I think I would say in general for I would echo what Dr. Milt Rossman mentioned before, is that maybe because there are some concerns about putting people on prednisone, that we will only treat patients if they really are showing consequences of the sarcoidosis being active. And then for the liver, it usually would be liver function tests that being abnormal. So in that situation that you named, if a person is found to have sarcoidosis on a biopsy, it's really not causing any problems with the liver function, then we generally would just simply watch that, you know, with repeated blood tests, you know, through time. We know that in other situations, classically, like decades ago, that patients can be found to have granulomas in other parts of the body, like say on a random muscle biopsy. But again, I think this is actually something that Dr. Ligon mentioned, that even if we see granulomas on a but on a muscle biopsy, if there's no evidence of either weakness or muscle enzymes, you know, like liver enzymes, muscle enzymes being abnormal in the blood, we're not necessarily going to treat that biopsy finding.
Okay, thank you. We've got a question right here.
Yeah, in my case, my father had sarcoidosis, and I have cardiac sarcoidosis. Question is, based upon the presentation, would it be worth establishing antibody titers in asymptomatic children and grandchildren at this time, so that if they should become symptomatic, you would have those baselines?
So certainly, familial sarcoidosis has been known to occur. In the ACCESS study, in African Americans, there was about a 10% incidence of a first-degree relative having sarcoidosis. In Caucasians, it was about 1%. So we don't normally, if somebody has sarcoid, go start looking at family members to see if they have it, because it's just so rare and it's not worthwhile doing.
Okay, thank you. We've got another question in the front.
Yeah, hi, I'm Mary Richmond from Central Virginia. I'm not exactly sure how to ask this question, but I'll phrase it. I made my living as a healthcare professional. Is my corpse any good to you guys? And is there a way to get it to you?
That's a good question, actually.
Is there a system? You live in a different state, you want it to be fresh, you know, how do you? Is it of any use to you?
I can actually answer that question. I'm over here. I'll go to the front. On our website, we have resources, depending on where your state is and where you're located. There is a company that will use your body for its necessary needs. So that all that information could be found on our website as one of our resources.
They kind of link you up.
Okay.
to
They
the
link
right.
you to the right connection.
Yeah. But
Yeah.
Good question.
Great question. We've got another question in the back.
Okay, thank you. Next question.
These are both, well, it's going to be, I'm going to treat it as one question, but it's actually about two different drug courses. My husband over here is on Remicade, and the first time he got a infusion, he just cleared completely up. He had skin sarcoidosis, but it's never done it since, although things seem to be under control. If a TNF factor type treatment fails, what does that mean in terms of any other ones? That's one. And I heard someone say thalidomide up there, but that's the first I've heard of it, other than through the skin doctor that he sees. And I was just wondering what, if you didn't do well with methotrexate, if what that might mean regarding thalidomide.
Thalidomide is also an anti-TNF drug, and it has a lot of toxicity, much more so than Remicade. So it might be something to consider depending on the situation. The other thing is there are other biological agents that can be used. Certainly, there are some people who will fail Remicade. They'll be used Humira or some of the other TNF drugs. And then there are also some experimental therapies with anti-B cell therapy. Rituxan has been used in some difficult cases. But there are other drugs to be used and or perhaps experimental therapies. But again, it depends upon the nature of the involvement and the severity of the involvement that determines that choice.
I might just add, because we see it a lot in rheumatoid arthritis, especially if you had an initial good response and then lost that response after a while, again, antibodies can be made, and infliximab is one that's particularly prone to that. You know, maybe worth trying another TNF alpha.
Yeah.
Okay, thank you. Got a question over here?
Hi, good afternoon. My name is Juanita. I've had sarcoidosis for over 20 years. I was diagnosed at VCU, so I do have to piggyback on if you find research hospitals are a viable source in finding out those types of things. But the question I have is, I have sarcoidosis in several different areas. So my progression has been extremely haphazard and very different. I think I've been lightning struck 5 times maybe. I just recently was diagnosed with fibromyalgia. I also have degenerative arthritis, as well as the complication with the sarcoidosis. And recently my skin and the rheumatology seem to work in concert with each other. I don't really have too much going on with the lung area. And so basically I don't really need to see the pulmonologist, but my question would be, when it goes dormant in another area for which you have multiple areas of prognosis, what strategy should you be using so that you do not bankrupt yourself to doctors and visits that are not necessary? So I say this to say, should I be seeing the pulmonologist while I'm dealing with the rheumatology issue or the skin issue? And my doctors fortunately do speak to one another, but I have not yet heard the pulmonologist say, have her come back in. You know, and I don't want, it started in my lungs. It went from lungs, I had the skin test. The skin test diagnosed it. I had a gallbladder surgery, and it was verified through a chest x-ray. So now in the last 15 years, I'm now dealing with the joint pain, which initially onset prior to my diagnosis. So I went 2 years not being able to walk hardly, to find out that I had sarcoidosis 3 years later due to a surgery. So I'm just kind of saying it's going back and forth. So I'm sure if there's other people that have multiple diagnoses, what do you do in terms of keeping yourself from going to 5 or 6 different doctors and again, bankrupting yourself?
Well, I guess your story is not that uncommon for people who have sarcoidosis in more than one part of the body, or at least clinically important sarcoidosis in more than one part of the body. There are generally probably two approaches to your situation. One would be that if one of your doctors, and I'll just throw it out there, not knowing, but possibly the rheumatologist, if one person was able to kind of take a step back and be willing to say, well, I can see this patient. I've known this patient for many years. I have a good sense as overall, what the sarcoidosis has behaved, in each of the different parts of the body. That would be maybe the only situation where you might be able to maybe see one person. But in many other situations, if you had, activity in your joints, causing you to, go to the rheumatologist, and then, if that rheumatologist is not comfortable with following the active skin disease, then you end up seeing both of those. One related question you sort of mentioned would be that, and what you've sort of told us with your stories, that sarcoidosis, even in the person where it may have involved many different parts of the body, doesn't have to be active all at once in all 5 parts. So, I think as you've done so far, can certainly cut back and not go back to the pulmonologist if that area has not been involved, for a number of years. So, yeah.
Okay, thank you. We've got a question in the front.
Thank you. Hi, Alicia O'Neill from San Diego. Came very far to see you guys.
Thank you.
Yeah, thank you, really, because this is huge. In San Diego, there's nobody who knows what they're doing at all. I know more than they do, really. But I was diagnosed in 2000. I went with the doctors at UCSD. They almost killed me, honestly. 2.5 years ago, I decided to do something different. I took myself off of all the meds, changed my diet, started exercising. I used to be in a wheelchair, and I was stuck in the house for 10 years. I'm doing much better, obviously, which I'm really happy. But there's a cyst issue on my organs, and nobody can tell me what's wrong. Breast, kidneys, liver, like a cystic issue. Have you heard about that with sarcoid? Because I can't get an answer with that one.
Well, I think generally sarcoid doesn't cause cysts,
Right.
though it can cause some, with destruction, you can get certainly cysts in your lungs from it. It's from end-stage disease, but generally a cystic disease in other organs is, I would think one would look for other causes rather than sarcoidosis. Again, sarcoidosis is a diagnosis of exclusion.
Right.
Actually, so I wanted to mention something because it's triggered by your story and related with something I'd mentioned before. Right? One issue really would be the sort of like the unmeasurable benefit of sort of like rehabilitation and physical therapy, right? And so I think one thing that, again, that it's very easy for patients to kind of start with, problems related with their active disease, whatever symptoms they may have been, and those, when the active problem, when the sarcoidosis was active, certainly could have been severe enough to keep you from doing anything. And then, once a person's, has the sarcoidosis under control with medications, it's not as if they usually don't suddenly feel normal. There may be other issues, maybe side effects of the medications, maybe just simply they were deconditioned on top of whatever happened with, through the sarcoidosis. That last part of really getting them back on their feet and more active is very difficult. It's not a mental thing, but it's just very, very difficult. And it sometimes gets really overlooked. They start with one problem, and not that there's a big break in their story. They kind of slowly slip into, at the end, lots of deconditioning, weakness, and on top of that, probably some weight gain.
Yeah.
So I'm glad to hear that you were able to at least do that. Hopefully one of your doctors, strongly encourage you to do that, but that's something that I think that we really need to keep in mind. Physical therapy is really important.
And I've even found that exercise, if you can exercise every day, even though it's difficult because we're all so exhausted, you do better with your symptoms.
Right. I think that's really important. We to be frank, we don't know exactly what the real benefits in terms of measuring things of exercise are, but we know that definitely it is important. It makes people feel better in many ways, It's one of the few things that we know that helps, for example, fibromyalgia, another issue that we don't really understand very well. So it's a good story to hear.
Okay, thank you.
Thank
Got
you.
questions in the back?
Yeah, I'm Ann, and I live about half an hour from here. And what I wanted to find out was if somebody had neurosarcoidosis 25 years ago and was on prednisone for about 3 years, and it's been dormant for the last 22 years, and then suddenly starts getting numbness and tingling in the legs, how would you determine whether that was sarcoidosis related or possibly CIDP or some other neurological thing? What tests or people would you go to try to sort that out when, you know, the neurologists are likely to say idiopathic neuropathy? The biopsies show, not the biopsies, the CNS shows the nerves are okay, but there's some muscle involvement. It just...
Again, it's, you know, we talk about sarcoid being a diagnosed exclusion, so if you're developing a numbness in your extremities, you would probably need to be seen by a neurologist who deals with neuromuscular disease and probably have nerve conduction studies, a biopsy maybe, to try and figure out what it is. Certainly sometimes, you know, as people get older, if they have diabetes, this can cause nerve conduction problems and other things. So it's, one would have to sort of try and figure out what the cause is. And, but one certainly wouldn't immediately, if you had CNS sarcoid 25 years ago, and it sounds like you had a very good result with that, immediately attribute some nerve, peripheral nerve numbness to sarcoid. You need to be sure that there was not some other cause.
Okay, thank you. We've got about 10 minutes left, so we want to get to all of our questions, so please keep them brief.
Okay, one more question in the back.
Hi, my name is Dana, and my question is, this is kind of a SOS for us, I guess. My sister's had sarcoidosis, I don't know, she got diagnosed 9 years ago. She has severe scarring in her lungs, but the problem I have is, and she has it in multiple places, okay? But the problem I have is we need to know, or I need to know, what she can do. She didn't know how sick she was, I'll be honest. It was never explained to her the illness that she has by the doctors that she had. We almost lost her about a year ago. They put her out for a routine surgery, and they couldn't get her back too. The doctor that she had, the new doctor that she had, really didn't know how sick she was. Now they're trying different things on her, but she's not getting any better. She's actually getting worse. So I just really want to know what steps do we take to preserve her life. She's here because she wants to live.
In this, I guess in this situation, you know, obviously I don't know all the details about this person's, you know, condition. So in order to maybe discuss this, I'll just simplify it in a way. Let's just say that, you know, your sister is now found to have very heavily scarred lungs, you know, from sarcoidosis. So. She's here. I'm sorry. But no, I know she's here. No. I mean, just I don't think it's. You know, we don't want to turn this into
to an individual.
Right. This is not a clinic visit, but so. But what I'm trying to say is that just so in a patient who has, you know, end stage organ damage, you know, from sarcoidosis. You know, it gets back to this issue that scarring won't get any better with any dose of medication. But you also, I mean, particularly with patients whose lungs are very bad, we certainly don't want them to get worse. So it's a balancing act of using at least what we call, or doctors will think as a reasonable dose of medication to keep the sarcoidosis from getting worse. Now, what that specifically means is that more is not better. And so throwing 20, 40, 80 milligrams of prednisone is not going to make this person better. When an organ like the lung fails, then other things certainly can happen. The person may need oxygen. It may put more strain on the heart, so a heart problem can come up. And then on top of that, you know, again, it's this issue that a person gets sick, they become less active, and they, you know, are very deconditioned. So I think that, again, just boiling it down to, number one, make sure that the person is not showing signs of the lung disease itself not getting worse. Number two, making sure they haven't incurred another medical problem like a heart problem on top of that, which can be directly related with end-stage lung disease. And the third would be that, again, it would be important in this case to see if the person should be referred for a course of physical therapy. In this case, it would be for something called pulmonary rehabilitation. It's a specialized physical therapy program for patients with lung disease. So it's not the same as just telling a person to just simply go and exercise and walk around. It's not fair for them to just simply say that. But going to pulmonary rehabilitation, the staff is there geared to work with patients with bad lung disease. And usually, at least it often may help improve quality of life in some cases.
Let me just add one other thing here, is that sometimes therapy isn't successful in sarcoid. It fails, the organ fails. And transplantation is an option in sarcoidosis. Lung transplants have been done for people with bad lung disease, heart transplants for people with bad hearts, and liver transplants have actually been done for people with bad livers. So when all else fails, transplantation is an option for people if they qualify for it.
Okay, thank you. Next question.
Good afternoon. My name is Michelle. And first of all, I want to say to all of the staff from Johns Hopkins, if I lived 2 lifetimes, I could never be grateful enough. But my question is, how do we get the rest of the medical staff, doctors, nurses, whoever, to get on board with, I hate to say it this way, but if you don't, admitting that you don't know and saying, hey, let me send you somewhere else. Because in my case, I actually had a doctor that was getting ready to commit me because he said I was crazy because I kept coming back and saying, I don't feel good. There is something wrong. I was swollen to the point where you poke me and I would have an indentation in my muscles, but it was a mental thing. So how do we get the rest of everybody else involved in this? And like I said, it was almost suicidal. And if it was not for the last neurologist that I saw, and I just broke down in his office and said, I can't do this anymore. I said, please help me. And he was like, do not let another doctor touch you until you get to Hopkins.
I think this is actually something that the Foundation for Sarcoid Research is actually trying to address with their educational programs for physicians to try and increase physician awareness of what sarcoid is, why they have on the website these various treatment protocols for the different forms of sarcoidosis. So I think it's sort of trying to educate physicians about it, to make them aware of it. Sarcoid is an unusual disease. There are many physicians who never see it and don't know what to do when they see it. And so it's a question of education and trying to make more people aware of it. And I think that's something that the foundation is trying to do.
Yes, thank you. That's absolutely true, and I think that part of our focus is specifically around those professionals who don't see much sarcoidosis. There are these incredible clinics and centers of excellence throughout the states, but there's also your GP who again has never heard of it too. So that's part of our awareness campaign, if you will, is to reach out to all constituents, all stakeholders. And again, our goal is not to to push any one therapy or to push any one doctor or any institute. Our goal for everyone is to inform people of the facts. What is available, what's out there. It may not work for you. It may not be the doctor you want to see. It may not be the answers that you want. But we need to give patients and doctors access to this information. So that's kind of where we are on that. And hopefully, sometimes doctors don't want to hear, they don't want to learn too much about it if they don't see it much, right? But as much as we can get the information out to them so they have it at their access, that'd be great.
Okay, thank you.
Okay, my question probably is going to sound really naive and simplistic, but one of the other ladies that was here that goes to VCU kind of had the same path where I had pulmonary, joint, and skin affected. And I changed diet and worked really very strongly to get inflammation down in my body so I didn't have to continue on prednisone. But since that time, it has flared back up. And the thing that I'm finding the most difficult to deal with at this point is something I haven't gotten an answer for, and that's the extreme fatigue and exhaustion that comes along with it. And my doctors have said, I don't know. I continue to say, why am I so tired? What can I do to improve that? What can I do so that, you know, by the time I get up, take a shower, I don't need to lay back in bed because I'm totally exhausted from doing that. So are there vitamins that you recommend? Are there particular foods you recommend? Are there medications that can help?
I think fatigue can be an extremely difficult symptom to treat in sarcoid. And while Ed has talked about exercise being helpful, and sometimes it does, sometimes it doesn't work. And people have tried various drugs with it. I don't think any particular drug has universal work with it. People have, in Europe, they've certainly talked about small fiber neuropathy being a part of the fatigue, and people have actually used some of the anti-TNF drugs for severe fatigue with some success. People have also used stimulants to treat fatigue. There's a whole variety of things that people try and treat with it, but it's unfortunately there's nothing that works universally.
Yeah, fatigue is so multifactorial, and there's so many things that go into it. Yeah, it's nice when you can find something that you can, attack it with. Sleep apnea is a common problem in all these conditions that can help sometimes if you treat it. It's a common problem in rheumatoid arthritis as well. I think there's some data in the rheumatoid literature for anti-IL-6 treatments, which is something I think that's starting to be looked at experimentally in sarcoidosis as well. But yeah, unfortunately, there's no kind of blood marker that I think we can really point to that correlates with that, and it's really just kind of treating what we can find that's abnormal and trying to optimize everything else. And again, fibromyalgia being so common, and fatigue is also a important component of that. So certainly treating that when you can sometimes help as well.
Okay, thank you. This is going to be our last question.
Hi, I just have a question I haven't heard yet, and I wanted to mention my age. I'm 35, and I have pretty significant sarcoid throughout my body, and now an onset of high blood pressure, which is causing AFib for me, so I may be a familiar question for you. Is that something you guys have seen throughout your research, or something you've run into? Because in my readings, I haven't seen anything in regards to high blood pressure. Also have a known hemolytic anemia. I don't know if that's also something you guys have run into. But at 35, I don't want to have to take high blood pressure medicine, but it's pretty high, so I'm stuck on it.
I think most of the time high blood pressure related to sarcoid is probably a complication of the treatment, usually related to the steroids. But certainly hemolytic anemias have been described in sarcoid. Yeah. It's rare, but has been described.
I would have to agree that usually we don't think that sarcoidosis directly causes high blood pressure, but complications from corticosteroids or another complication indirectly from corticosteroids would be weight gain leading to, say, sleep apnea could certainly lead to high blood pressure. And whether or not the high blood pressure itself might be causing atrial fibrillation, certainly that's the usual excuse we give if the person's in most older people. In a person your age, I wonder, it's not common for cardiac sarcoidosis to present as atrial fibrillation, but cases have been described, and so if that's sort of a new issue, atrial fibrillation, I think it's probably worth investigating that. Well, just having it checked out and making it see if a cardiologist.
Yeah, the challenge with doing any of the imaging studies to look at atrial disease is there's very limited sensitivity. So, when the atrium it's very, very thin tissue. We're talking about millimeters thick. compared to the ventricle, which is probably about a centimeter or so. So it's sort of 10 times as thick. And when you have very little bit of tissue, any of the imaging modalities are going to be very, very limited in seeing disease. So when we use PET scans or when we use MRIs, we often can't see the scar in the atrium. And in many ways, people present with either too slow heart rates, like bradycardia. We put in pacemakers because people's heart rates are too slow, or they develop atrial fibrillation and things of that sort. So I don't, me personally, I don't chase after imaging people repeatedly if there's atrial disease-based sort of entities that people are worried about. We just sort of treat the condition. Now, just sort of parenthetically about atrial fibrillation, as you know, this is one of the most common sort of arrhythmias that we see in the absence of sarcoid or even the presence of sarcoid. 10% of the population over 80 have it, and as you point out, it's really a disease of the elderly, as opposed to the disease of the young. There are some family sort of based syndromes that predispose people who are younger in their 30s. I've had a handful of individuals in their 30s or 40s with atrial fibrillation, but that's not the norm. It's more the uncommon thing. And there are a lot of therapies to treat that. But I don't know if I would necessarily jump straight to saying that this is a manifestation of cardiac sarcoid per se, as opposed to something else that just maybe in your genes or some other entity.
Great. Well, we're at the 1 o'clock hour. I'm sure everybody's hungry. Before we break for lunch and come back, I do want to give the panelists and our gratitude, which we all I know have. They may, or they're welcome to stay for lunch, or they may have to go. I'm not sure, but please do give them a round of applause, and thank you so much, so very much.